Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Colchicine in dermatology. Coming to its definition, colchicine is an alkaloid extracted from seeds and tubers of the plant Colchicum autumnale. This plant is also known as meadow saffron. Here in this plant, every part contains this alkaloid called colchicine, but it is found in higher concentration in its seeds and tubers. Tubers are nothing but the underground part of the plant through which new plant arises. Coming to formulations available are only oral. Here why I wrote purposefully this word only, you will get to know by the end of this video. Next, coming to its pharmacology. It is absorbed well from the gut and reaches its peak in about 30 to 120 minutes of its ingestion. T-half is about 20 to 40 hours. It is metabolized in the liver by enzyme CYP3A4. Remember this enzyme? We will speak about it again at the end of this video. It is metabolized in liver and excreted via liver only, mainly 80 to 90% through bile and feces. The rest, just 10 to 20%, will be eliminated through urine unchanged. Without any metabolism happening, the unchanged drug will be eliminated in urine about 10 to 20%. Remaining rest of all the drug 80 to 90% will be metabolized in liver and excreted through bile and feces. This drug colchicine must be shielded from sunlight, that is, it should be protected from sunlight because UV radiation will degrade this drug into therapeutically inactive products. It will become useless if it gets exposed to sunlight. Coming to its mechanism of action. Colchicine, after ingestion, it will get concentrated in leukocytes, mainly polymorphonuclear leukocyte, that is neutrophil, and persists inside the cell for several days after ingestion. It has both anti-inflammatory and anti-mitotic properties. How it is going to exhibit these properties? First, coming to its anti-mitotic property. It will bind to tubulin and blocks its polymerization to form into microtubule. Thus, it prevents microtubule formation. If there is no microtubule, there won't be any cell division. Microtubules are essential for separation of chromosomes during mitosis at metaphase. Thus, it results in mitotic arrest at metaphase. Next, coming to its anti-inflammatory property. All these anti-inflammatory properties are also due to its inhibition of tubulin. What happens if tubulin gets inhibited? There won't be any intracellular motility and it prevents chemotaxis of neutrophils, lysosomal degradation, and formation of inflammasome complex, thereby inhibiting interleukin 1 beta. All these are linked to tubulin. Here, interleukin 1 beta is a pro-inflammatory interleukin which is activated by caspase 1. If all this have to happen, there has to be formation of inflammasome complex. Here, colchicine inhibits this complex, ultimately inhibiting interleukin 1 beta. What is the other biologic which is against or anti to this interleukin 1 beta is canakinumab. Here we will produce monoclonal antibodies selectively against this interleukin. But this plant already got this product called colchicine, which inhibits this interleukin. Coming to its uses, both dapsone and colchicine is acting against neutrophil, but colchicine is useful in only some diseases. It is used for centuries. It has been used for gout and familial Mediterranean fever. If I have to say accurately, it is used for acute gout and in prevention of attacks and amyloidosis associated with familial Mediterranean fever. It is one of the periodic fever syndrome. These two are the only FDA approved uses. There is no specific FDA approved uses in dermatology. Only off-label uses in dermatology are neutrophilic or bullous dermatosis A, B and D. For A, epidermolysis bullosa acquisita, linear IgA bullous dermatosis, IgA pemphigus, aphthous stomatitis. For B, Behçet's disease, D, dermatitis herpetiformis. These are all neutrophilic dermatosis. Here, IgA pemphigus, accumulation of neutrophils occurs in epidermis. In linear IgA bullous dermatosis, Behçet's dermatitis herpetiformis, in dermis, neutrophils will get accumulated in dermis. Next, vasculitis, leukocytoclastic, urticarial and IgA vasculitis. Here when we study urticarial vasculitis and IgA vasculitis, in its histopathology there will be given like this, similar to leukocytoclastic vasculitis. That means accumulation of neutrophils within and around the vessel walls. This is the feature in this vasculitis. Coming to next use, papillosquamous diseases like psoriasis, palmoplantar pustulosis, connective tissue diseases like scleroderma, dermatomyositis, relapsing polychondritis. Others like actinic keratosis, anitoderma, type 2 reaction, pachydermoperiosteitis. Here in actinic keratosis, 0.5 and 1% topical formulations of colchicine will be useful. But this topical formulation is not widely available. That's why I didn't write in formulations available topical. What is pachyderma? Pachyderma means thick skin over face and scalp. Over scalp, it will look like cerebriform structure of brain. So it is called as cutis verticis gyrata. Here you can observe thick skin over scalp like that of a gyri and sulci of brain. That's why it is named cutis verticis gyrata. This same pachyderma, thick skin over face, it will give a look of leonine faces. So we can write this in DDs of leonine faces. What is anitoderma? Opposite to pachyderma. In pachyderma, skin will be very thick. Here in anitoderma, due to loss of dermal elastic fibers, skin will be very loose, called slack skin. Coming to adverse effects, for every drug we can write nausea, vomiting, diarrhea. Here for colchicine, it is the most common adverse effect, that is GI adverse effect, nausea, vomiting, diarrhea. Next, hematological adverse effects. Myelosuppression. If bone marrow is suppressed, all the cells will be suppressed, leading to pancytopenia, ultimately aplastic anemia. Neuromuscular side effects, rhabdomyolysis, myopathy. Toxicity. Colchicine is a very toxic product. I already told you, entire plant contains this colchicine, so entire plant is toxic. Colchicine has very narrow therapeutic index. If taken more than 0.8 kg, 0.8 mg per kg, it is fatal, causing cholera-like syndrome. C for colchicine, C for cholera-like syndrome. In cholera, there will be profuse diarrhea leading to dehydration, renal failure, ultimately shock. Because of this dehydration, there will be electrolyte imbalance, acid-base imbalance like hypokalemia. In hypokalemia, it will affect heart also. So there will be multi-organ failure, hyponatremia, metabolic acidosis. This is very toxic product. If we give IV injections, it may prove fatal even on bed while infusion itself. So no IV colchicine is available. That's why I didn't write IV injections in formulations. How do you treat this toxicity? There is no antidote to treat this toxicity. Even dialysis is not effective as this drug is highly protein bound. 99.9% of drug will be bound to plasma albumin. Even if you do dialysis, it's not effective. Only thing we can do is gastric lavage to remove the drug which is not yet absorbed, and then supportive care means treating symptoms, treating complications. I told you to remember the enzyme CYP3A4. Whatever the drug inhibits this enzyme will lead to increased serum colchicine levels. What are those drugs? Statins, simvastatin, atorvastatin, lovastatin, macrolides like erythromycin, clarithromycin, azoles, ketoconazole, itraconazole, and fluconazole only if prescribed above 200 mg dosage. Calcium channel blockers like diltiazem, verapamil, calcineurin inhibitors like cyclosporin, tacrolimus. Calcium channel blockers, calcineurin inhibitors. Fibrates and food like grape juice, fibrates like fenofibrate, gemfibrozil. In this entire topic, the letter A came many times, like in drug interactions, azoles will lead to increased serum calcium levels. In uses, anitoderma, IgA bullous dermatosis, IgA pemphigus, epidermolysis bullosa, acquisita, aphthous stomatitis. Actinic keratosis, anitoderma. Antimitotic property, anti-inflammatory property. Don't forget to like, share and subscribe this channel, The Average Derma Doc. Thank you. Hasta la vista. Dasvidaniya.